So I hope Jeremy will come. He's my co-moderator for the first part about introducing this, the educational part of the session. So this session is about new technologies and AI, and I'm very excited about this session because we'll see really interesting talks. The first presentation is Chun Yuan presenting recent developments in vessel wall imaging. AI is an analysis, I guess. So.
Thank you. Yeah, thanks for the introduction. And also thanks for this small audience. I was told I need to be on time for 13 minutes. We'll just keep on going until whoever, okay? Yeah, this is I'd like to focus today on this so-called vessel image analysis. But a little background on this is a publication we had in 2001. And that's sort of a starting point of looking at this vessel imaging. And this is a picture of carotid artery and using this so-called multi-contrast weighted images and looking at both the lumen of the carotids and also the plaque itself. And this is the beginning point of trying to stay away from simply looking at stenosis. But what is interesting is up to now that even though these images are about 20 years old, I think that the image quality of this are still pretty comparable of what we can do now. And the other thing is, even though this provides a lot of information, it's still not in real clinical practice. It's still limited in centers who are doing research and other places who have particular interest in looking at the vasculatures. One major recent advancement in this field, in fact, is this paper published and with Luca Saba as the lead author with a group of so-called experts in this field, introducing this plaque red. It's a way to reporting what you see on images, not limited to MRA, but also CT and ultrasound. And also it's intended to grade the system with a number to say, you may have a high-risk plaque and you may have a stable plaque or whatever that is. And I think that this actually is a accumulation of many work in this, many experts or research people in this field to get to this point. And the other thing that is interesting is, this is in about 2007 that we introduced this software called Cascade. The intention is to analyze carotid arteries based on this multi-contrast weighted images and generating quantitative numbers out of them. And then if you were to look at this, there are a fair number of things you can report. For example, you can look at thickness of the wall. And you can actually identify where the lesions are, and therefore you can actually measure the volume of lesions. And you can also look at the composition in this. And this is also where we started, if you think about vessel imaging, most of the imaging research may actually be focusing on how to improve the image quality, and then you can see things better. But in this case, once you move from the beginning point of looking at vessel wall, the so-called how atherosclerosis, how does it look like on imaging? And what is the history of this atherosclerosis development in human? In fact, really did not exist. There were histology studies, but there were really no information based on humans. You can actually see this is what early lesion, later lesion is. So when this technique is being developed, we're also learning the nature of the disease. And I think that actually is a very different aspect of imaging. In this case, I think MRI imaging played a key role of its development, especially for the carotids, because of this so-called importance of intraplaque hemorrhage. You have heard many talks in recent days about this is a so-called high-risk factors and so on. But this entire thing is because of MR's ability to identify intraplaque hemorrhage in the first place. We started to realize this is an important thing is happening in atherosclerosis, especially in the carotids, and we should actually be having better understanding of it. And then part of this quantitation really is for that purpose, in my mind, is that we should actually be able to identify different tissues and quantify them and understand how they actually evolve over time and how do they correlate with the development of symptoms in patients and so on. And the other thing I think is interesting is all these measurements can be quantitative. And before that, the only measurement people have, in fact, is stenosis. So a real challenge from this, actually, from the point of imaging, of looking at stenosis, of looking at vessel wall, is all of a sudden you're dealing with a lot of different numbers. And we really have no clue that which number is really important. For example, whether plaque burden and stenosis actually are the same thing. And if you believe a plaque can develop without impacting lumen in the first place, and then plaque burden may actually be a more important measurement. So those are, I think, are the background of why this has been so challenging, and it's taking so long to bring this into a clinical practice. But from the image analysis point of view, I think that there are a number of issues we're dealing with. For example, the beginning point of all this imaging was 2D based, and now we're migrating into 3D. 3D means you are able to actually look at the lesion in any angles. And then the information you can get from looking at the same lesion from different angles may actually be very different. And the other thing you also heard from today from this Dr. Narula's talk, in looking at peripheral arteries, carotids, and coronary arteries, every single artery's so-called atherosclerotic lesion, the composition may actually be very different. When you simply just refer this as a stenosis, I think it's you're really missing a lot of information. But once you started looking at the others, their signal features may actually be very different depending on which blood vessel territory you're looking at. For MR, I think that we're very used to the point of there are a lot of artifacts, and then the signal contrast can be changed so easily by tuning your little imaging parameters here and there. Each of these leading to some variations in signals that you have to deal with. To us, I think that being able to use this kind of imaging in serial fashion so you can really see how atherosclerosis develops in human, because that development can take decades. It's not in days. And this decades information, if you want to actually see it over time, I think being able to register this time data will become an important issue. Signal normalization is certainly it's always going to be a challenge. But I think the last one of this, in fact, is also a big thing, is most of the current radiologists are never trained to look at vessel wall imaging in the first place. So they don't really know, even if you provide the best images to them, I don't think they can actually give you a good answer of what they're looking at. So those are, I think there's a series of challenges of dealing with, of looking at, once you go beyond stenosis, and you want to claim that you want to look at vessel wall, I think those are the fundamental challenges that people have to deal with. And then I would just give some examples of the attempts people are doing in this area of so-called quantitation. This is an imaging sequence. It's called 3D merge. It's intended for a very quick coverage black blood acquisition of carotid artery. It only takes about 2 minutes. And so if you're able to put a patient on and off in 5 minutes, you can do many patients per hour. The real is challenge there. So if you can do that, I think that you can almost argue that MR is cheaper than ultrasound for screening carotids, because you can see beautifully where the artery is and the distribution of the lesion and so on. But if you have images like this, if you want to process them 3D with so many slices, if you need a human to go there to actually identify lumen and outward boundaries and then measure so-called thickness and other things, this becomes a total nightmare because it takes too long. So we have been trying to actually come to a so-called a good way to process the data. This is one of the early attempts we did, and this is an AI-based, neural network-based approach. Is we think that if you are able to build this, identify where the arteries are first. The second is locate a so-called bounding box around the arteries. And then at each location, if you're able to say whether that is a normal artery or whether that's disease of different levels, automatically, then at least you can actually provide some useful information to the clinicians of what they are. So this is what that is. And this thing is called latte. That I come from Seattle, that everything is coffee based because we need to be fully caffeinated in order to be functional in rain. And then this actually migrated into something else because Dr. Carotid, this is more recent, and this is developed by a research fellow in Utah. And then the intention is supposed to say you can identify where the carotid bifurcations are in the images automatically. And if you can segment the lumen outer boundaries automatically based on some sort of algorithms, and these are neural network-based algorithms. And then we can actually calculate the thickness along the arteries based on in this case, is a Laplacian transform algorithm. And then this is the result. You can actually see at the other end and what it is. And this is the intended report coming out. You can actually identify, for example, the red areas are the diseased areas with increased thickness, and the color will be a reflection of thickness and a reflection where the diseased arteries are. And the intention of this is a fully automatic. And then this is work by a different group this is from Renji Hospital in China. And they're trying to expand something like this into including both carotid and intracranial arteries and trace the lumen and then generate this so-called MPR view of the artery itself for improved way of looking at the lesion itself or focus on the analysis. Another group, this is also a recent publication using a deep learning neural network-based approach of looking at segmenting cross-sectional images of where the arteries are and of lumen outer boundaries, and therefore the so-called composition of the lesion. And another aspect, I have only 1 minute left, so I will just go very quickly. Another aspect of this that is, I think is interesting is, this is a sequence called SNAP, and it's generating this so-called heavily T1 weighted imaging for highlighting intraplaque hemorrhage. Then one question is, if you have images like this, you can just threshold the image, identifying where the arteries are, and then thresholding those. You can automatically detect what IPH the intraplaque hemorrhage is. So this is indeed Jin Liu is a graduate student, a PhD student in our lab, and then she did this work, using thresholding an artery, and without doing anything, you can actually generate a map of where the IPH is, their volume and distribution. And this is then further extended into an automatic AI-driven algorithm shown here that suppose you're able to identify the bifurcation, and then you're able to use this the same sequence to look at where the lumen is, and then also there's a so-called bright signals of the vessel wall to generate an automatic IPH map, and therefore its volume. So this is it's an automatic IPH detection. Therefore, it's a signal intensity based analysis tool. One more slide, sorry. And then the other thing I just like to sort of summarize this, and my time is running out, is this technique now is also migrating into looking into intracranial arteries. But the challenge of intracranial artery is the artery is very small, tortuous. And then you have to look at, if you want to look at the lesion with multi-contrast, you want to actually be able to create cross-sectional locations at any area along the artery. So that creates another challenge. And then we sort of went through pretty complicated process of eventually getting into this software we called MoCA. You actually see multiple presentations from University of Washington that on this using MoCA for the data analysis. The simple point of this is through all these different algorithms, we want to create MPR views of any segments of the intracranial artery, display those particular locations that you want to do analysis on. We also want this algorithm to be able to bring MR images and ultrasound, the CT images together because they're all 3D based. So if you look at these images, the last image, in fact, is the CT based image. And where the calciums are, this is highly calcified lesion. On MR images, they're almost completely missed if you don't look at them carefully. But if you look at the time flight and also black blood images together, you can actually appreciate where the calciums are and also the soft plaque, where they are. And both of this combined together and looking at them this way, it can be very useful. And another thing that we did in this is we use this type of map as the base to generate something called contrast enhancement map. That becomes a 3D distribution of the data. So I will just conclude there to say that this is I think it's a very interesting area for data analysis, and there are plenty of work that can be done for both so-called segmentation and also for quantitation of different tissues, and also for different vascular beds in the body. This will be needed. I think different challenges that people have to deal with. I will stop there. Thank you.
Thank you very much, John. Just one quick question. Are these tools available open source? Just really, or are they, yeah.
I will use 5 minutes to answer that question. No, I think these are hopefully that we can, I think the problem we have, sorry that I represent myself plus the people that I have been dealing with. We tend to create all the softwares that are very difficult to use because I'm a believer of information. So I want the images to I want to get all the information out of those. If you want to use this in a clinical setting, I think that we need to streamline them to make them easy to use. The truth is, I think that what will be really interesting is if we can work with real clinicians in this to say, how do we zoom into the interesting areas quickly? Then we can use those effectively. That would be a beautiful partnership.
Thank you very much.
Thanks, John. And we're going to move on to the next talk given by David Marlevi from the Karolinska Institute in Sweden and MIT, also affiliated with MIT. Title is Super Resolution and AI in Cardiovascular MRI. David?
Thank you very much. Thank you for having me here. I'll give a talk today about super resolution and AI in cardiovascular MR. We've been hearing, not least from VIII in the previous session, but also during the last few days, the value of AI in what we're doing in image analysis. Sort of this spans from both first type of acquisition we can think of to the last piece of data quantification. For the sake of today's talk, I will speak about one specific area here, which we can focus on, basically super resolution image conversion, or the use of AI as a post-processing tool to enhance the resolution of our data. And to be even more specific, I will use sort of phase contrast imaging as maybe the basis of this. As VIII showed previously, this can be expanded into other types of imaging as well. The techniques I will speak about is sort of generic in that instance, but for the sake of full field phase contrast imaging of 40 flow MRI, we have this sort of triangle of trade-off between resolution, scan time, and SNR, which means that we have to sort of sacrifice resolution for the sake of the other two, or vice versa. And why is resolution important? Well, obviously it affects what we can visually appreciate across different vascular beds. It also appreciates what we can measure quantitatively. This is one example from colleagues in Chile about how 2D versus 4D phase contrast imaging diverges as we decrease both spatial and temporal resolution. We've also done similar studies in intracranial vasculatures where we see that estimations of intracranial pressure gradients from phase contrast data sort of decreases in accuracy as we go into sort of millimeter resolution as compared to sub-millimeter resolution. And these effects are actually exacerbated in complex disease, so we really want to increase resolution. So how do we improve resolution? Well, we can fiddle with our acquisition setting, be more clever with how we sample in K-space. We can maybe change our field strength as well, or we can go and sort of speak to our computational colleagues and try to do more fancy computational fluid dynamics setups to mimic what we are imaging actually. But if we want to stay with existing clinical systems, we have our scanner in the hospital. We don't want to change the sequence. We don't want to involve any experts that we're not working with yet. Can we enhance resolution post-scan if we already have the data there? Well, that's where sort of machine learning or AI comes into play here. So this concept of what we can call, or from the computer vision domain, is called single image super resolution, sort of has been known for quite a while. So if we go into the computer vision space, we go back 10 years ago or so, sort of this was approached using convolutional neural networks, expanded upon with what's called residual networks. We can go further in time. This is sort of fast forwarding through the developments of in the computer vision space. You can see that these are quite sort of seminal works in their domain, going from the left now, convolution networks, to the right into generative or even physics-informed networks. If we use the same timeline and look at what has been done in the MR space, well, a lot of work has been done, or I should say a lot, but some work has been done in sort of the domain of using residual neural networks, super resolution for 4D flow, super resolution for CNET data and whatnot. We're also seeing a few works in the last few years utilizing what's called PINs, or physics-informed neural networks. So we are maybe lagging 5 or 10 years behind the computer vision crowd, but they are the ones also developing these techniques. I will focus a little bit on this domain here, namely utilizing residual networks to enhance resolution, and span a little bit beyond that towards the end. So how do we implement a super resolution network or residual super resolution network to enhance our data quality? And I will again focus now on phase contrast imaging. We can think about it equivalently to other data spaces as well. Well, in this sort of supervised space, well, we do need training data, and training data for a supervised super resolution network, that means that we need pairs of high and low resolution data, either acquired or simulated. So for what, exemplifying from work that we've been doing, if you want to use paired high and low resolution flow data, well, the best sort of benchmark for that is to use these sort of high resolution CFD data sets, where we have both velocity and pressure resolved in a high fidelity space. We can dump that onto an equivalent voxelized grid, and then we can generate sort of patches of velocity data at arbitrary resolutions that we pair and then feed into a network. So once we have the training data, then we sort of want to mimic clinical image quality. We don't just want to take the CFD data and say that this is our phase contrast data. Well, what we can do then instead is to sort of convert this simulated phase data into a complex value signal, represent it in K-space, apply noise or sampling patterns that we would do in the camera. We can even reconstruct it in certain specific ways to, again, sort of conform it onto what we're actually seeing in a clinical setting. Another example of this done by one of our students, Pia Kalmer, sort of having a more refined approach. We're actually using, in this case, a 4D flow sampling patterns, using a compressed sensing reconstruction to, again, recover all the sort of artifacts that you would see, or artifacts or features that you see in low resolution data, to sort of have the network learn how does a low resolution equivalent look like and how does a high resolution equivalent appear, and then learn the transfer between the two. So with training data, the second step would be to sort of define your architecture. From a residual convolutional perspective, it's fairly simple. You have here in the middle, highlighted in purple, a sort of a centralized upsampling layer. And then to the left and right of that, you have different convolutional networks and residual connectors. On the input side of this network, you would feed these patches. You have patches of high and low resolution data, in this case, of phase contrast data or simulated phase contrast data. And to the right, you have sort of the denoised upsampled equivalents of those. The third component that you then need to define is your what's called the loss function, which means sort of what is the network minimizing over? What does it try to learn? Well, in the most simplistic case, you can say just minimize the error between your high resolution data and the predicted data that you have. Here in this particular instance, we have sort of separated minimizing the error of sort of what's happening inside the flow domain, where it tries to upsample or super resolve, and then what's happening in the outside, which means sort of the background where it's supposed to denoise, and then we're having some regularizer on top of that. And in this particular instance, I'll get to that later, there's no physics information included. This network doesn't understand anything, or the way it's been structured on this slide, doesn't know anything about flow or anything about MR. It just knows about how should I pair my high and low resolution data to the best possible case. Well, if you train this, it actually works fairly well. At the top here, this is sort of an acquired phase contrast data from a sort of bifurcation phantom. At the top, we have data fed in at 4 millimeter resolution, the equivalent reference data at 1 millimeter, then what sort of the network is inferring from the low resolution data set. And in this particular simplified instance, we can see that sort of from the Bland-Altman representations, velocities are acquired fairly well. We've done the same in the brain, where we see that sort of inferring low to high resolution data using a super-resolved network. And this is super-resolving by a factor of 2. So we're going, for example, from 1 millimeter to 0.5 millimeter resolution. We're recovering velocities fairly well. Now, if we, in the cerebrovascular space, we try to look at where this error accumulates, well, to no surprise, it's really at the boundaries of the vessel where we're having problems in sort of recovering velocities at the accuracy that we want. So direct estimates look fairly good. How about the sort of functional estimates that we can derive from flow? Well, we also looked at that. Again, repeating, now this is if we want to derive pressure variations in the intracranial space from either low resolution, which in this instance means 1 millimeter isotropic, or high resolution, which means 0.5 millimeter isotropic. We see that sort of we need that sub-millimeter resolution to really recover the spatial gradients that we need to then derive pressure information. Well, as a matter of fact, if we take this low resolution data, feed it into a super resolution network, we're actually recovering that velocity information that we need. So as a matter of fact, we're not just locally upsampling velocity, but we're also recovering the underlying sort of relationship that's needed for us to derive pressure from velocity. Together with Susanna here in the front and her group in Greifswald, we've also done the similar experiments in sort of phantom setups, where we against catheter measurements can see that we're actually recovering the bias that we're seeing at low resolution if we super resolve it to a high resolution space. So that's sort of a fly through sort of what you would need for, let's say, a residual super resolution setup. So in this particular instance, a network called 40FlowNet recovers velocity and pressures fairly well. The key application space that we've been looking at is the brain, because there the vessels are small, the vessels are narrow and tortuous. The question then is, where are we heading? A few final slides on that domain. Well, we can think about more advanced applications, more advanced architectures, or more advanced loss function. And I'll get a little bit to that. That's more on the developmental side of this. On the clinical side, well, we can think about what are the use cases, what are the task specifications, and how we want to sort of infer this data. So if you think about more advanced architectures, well, we've been started to look a little bit on this. I told you before that the issues that we're seeing in prediction is really around the boundaries of a vessel. So if we want to quantify, for example, wall shear stress, well, it's accuracy at the boundary that we're really after. One of our students, Oliver Willin Udebach, has been looking at sort of using more generative networks to sort of better enhance the boundary layer performance. The network is a little bit more advanced here. We're coupling sort of the predictive network with sort of what's called a discriminatory network to sort of advance our predictions. We can see in a simplified setup here that the difference in error between a residual network, the second row compared to a GAN-based network in the third row, is that we're actually improving estimates slightly along the border vessels here. Another alternative in how we advance our networks is to improve our loss functions. So a completely other family of domains is called physics-informed neural networks, PINs. And that's where we actually introduce some of the sort of underlying physics of either the hemodynamics itself in a phase contrast setting, or the MR system itself, if we're looking at MR images, where we couple both the data-based data matching loss with the physics loss. This has been explored across several works that I've highlighted on the screen, where we're sort of, and the benefit there is that we can basically, or in principle, have an arbitrary upsampling when it comes to resolution. And when we solve a physics-based loss, we don't just get upsampled velocities, but we also get the coupled pressure fields from that. A few other examples before I wrap up about applications. Sort of this is now, from the group that I'm leading in Stockholm, but also other groups around the community looking sort of at applications, not just in space. Pia Kalmer again looking at temporal super resolution, so using the same network, but rather converting in time, space, you convert in time, looking fairly well on simulated data. We've also now tried it on sort of in vivo cases as well, where we see that the comparison network is doing a good job at both denoising as well as sort of upsampling from, in this particular instance, doubling the temporal resolution. So for example, 40Flow at 40, but now 20 millisecond resolution. We can imagine other super resolution advancements. We have explored sort of domain generalization, so looking at how a network explores not just about in a specific, for example, cardiac setting, but looking how a network can generalize across different vasculatures where we have different hemodynamic entities. Clinical usability can also be enhanced by sort of, wrapping all of this into one specific utility that you import, for example, into what vendors might be interested in. We've also seen some work here in Siemens-based collaborations with sort of porting this into a FHIR or open recon setting. A final slide before I wrap up as well, sort of one of the developments that we are discussing, and that's been discussed in the computer vision field as well, is sort of moving away from this black box idea that we have a super resolution network or an AI network that does something for you. But explainable or interpretable AI means where you're sort of adding a feature that's then saying, why is a network performing in a specific way? And there are a number of sort of entities that can be done to explore this. So my final slide, I see that my time is up as well. AI, a promising utility also for resolution enhancements. We've seen sort of the use of that across different domains. Development is still in early stages, but there are sort of a number of examples. I've focused on phase contrast, but other examples on the screen about how we perform super resolution in other sort of for other sequences in the cardiovascular MR space. So with that, I thought I'd thank you for the time. Thank you.
Thank you, David, for the excellent talk. And we'll move on in the interest of time to the next speaker.
So the next speaker, there you are. The next speaker is Mehmet Akşakaya. Did I pronounce that correctly? I hope so. And it's
That's
about,
perfect, actually.
yeah.
Yes.
It will be about streamlining workflows using AI from planning and reconstruction to analysis.
Thank you. Thank you for the introduction. One disclosure, I have a patent on the self-supervised learning technique I'll talk about for reconstruction, and we receive royalties from Siemens for that. So I guess at this point, I don't have to convince anyone that AI has become a ubiquitous tool for all of the MRA acquisitions that we deal with in the acquisition stage, the reconstruction stage, image generation, and also an analysis. Today, I'll try to give like a higher level overview of these, and I'll concentrate on 3 tasks. One is going to be the scan planning, so that'll be at the acquisition side. Then I'll move on to the image formation. So how do we go from these undersampled data sets? So how do we go from these undersampled data sets to a good reconstruction? And then obviously image analysis that we've been talking about, starting with the most basic one, which is going to be segmentation, leading into quantification. How can we visualize and do pathology detection? And I'll briefly touch on some of the open problems. So there are obviously other things that happen with AI, like you could do RF pulse design, etc., but I'm not going to touch on those. So I have been giving talks like this for a decade now, and I used to make a really effort about distinguishing artificial intelligence, machine learning, deep learning, and neural networks. But at this point, we're essentially using them interchangeably. So this is kind of old, but this still like applies. And usually all the things that we use are based on neural networks. So that would be what I would call deep learning about 5-6 years ago, but now we call it AI. These are models that estimate usually a nonlinear function between 2 sets. So this is going to be a mapping from something, which is going to be a vector space. That's usually going to be either the K space or the image space. And then you have an output that you want to learn, which could be a new image. So that could be in the image space, or it could be some sort of segmentation mask. So that could be a categorical variable that can only take values on a finite set. And then these, what they do in the deep learning setup is you combine multiple layers of simple modules, and then you can show that this is able to represent really complex functions. So this is true for predictive and discriminative models, that what we're going to talk about today, but it also applies to generative models, which is what most people think about when they hear the word AI, the chatbots or the image generation stuff. That would be, for instance, a mapping from one seed to an image that you want to generate. So the definition applies in both cases. So some of the intro, and this has already been covered in the previous talk, is, what do we learn essentially, right? We have a model that's going to be my neural network that's going to be specified by some weights. So these are going to be, let's say, the convolutional weights that we're going to learn. And there's going to be, a million to a billion parameters that I want to learn at the end of the day. And then what I do in the supervised setting, which is again what we saw in the last talk, we'll have some sort of input-output pairs. So that's going to be the target label that I want to go to based on the input data, which will be some sort of corrupted data to the clean data, for instance. And I'll keep showing examples like this to my model. And then I'm going to, over time, learn better quality of these parameters. And that's going to take a long time. And then, but the nice thing is the next time the data comes in, I can just apply this neural network without retraining, hopefully. And we're going to talk about that too. And then the model is supposed to predict the corresponding outputs relatively well. Okay, so the first part we're going to talk about is automated planning. And this is quite obvious. We want to, a lot of the things in cardiac is hard to plan. There's a lot of double oblique slices, etc., that requires good tech input. So we want to decrease operator-dependent errors. We want to have standardized protocols and improve the efficiency. And really all the vendors have something that targets these aspects. So AI to automate planning prescription and protocol planning. And there's also other startups or independent firms that provide these as well. So I'll try to focus on a recent study that highlighted this. So this was published this year that compared automated and manual planning. And the automated planning included a few things. One was automated positioning. So rather than the operator moving the table to the ISO center, this was done automatically. Automatic alignment, prescribe the standard localizers automatically, then adjust the sequence parameters based on the body size. And then other things that went into it is a plane prescription and also automated inversion time selection for delayed enhancement and other imaging like that. And one thing that is nice in this setup is there's that sort of interpretability or explainability where the operator can intervene and fine tune. So this is sort of a black box that's giving you an output, but you can still adjust the output. So this is some sort of human control there. So the quality was measured by what was classified as procedure errors. So this was, forgotten views when you incorrectly propagated the planes, if the field of view was misaligned or misassigned, and the radiologist recorded each of these. And then what they found was the automated planning was actually better in terms of providing rate of error, reducing the rate of error-free, improving the rate of error-free examinations. And then there was a slight decrease in terms of the study duration for free breathing scans, although breath hold took pretty much the same. So this is really something useful that's going to help everyone in their clinical practice, and this is being offered, I think, by all the vendors. Now, the next step is once you get that data, your data is in the frequency domain, the case space, so you want to go from that to reconstructed image, or you might want to just take your standard linear parallel imaging reconstruction and denoise it, or like we saw in the last talk, you might want to do some sort of super resolution. So in these cases, the problem is really based on some physics model here too, and we will talk about that as a physics-driven AI. So we have a set of observations. We have what we call the measurement operator or the forward operator, and this is known to us. And then we have some measurement noise. And then we are trying to estimate this underlying image, and we're trying to essentially predict that from our observation. So this is what we call an inverse problem. The measurement operator is usually known. There might be some uncertainty there too, but we usually take that as known. And then we usually know the statistics of the noise, which is modeled as complex Gaussian when you're dealing with complex data, or you might be doing some Racine denoising as well. In denoising, this is slightly easier. The forward operator is the identity operator, so you're just observing the original image in some noise. In reconstruction, it's a subsampled multi-coil operator, so that's a harder problem, but they're related to denoising. And one way to see this is to decouple the two problems. So the first one will be some sort of a denoising problem, and then the second one will be some sort of a data fidelity problem. And we're not going to really go into the optimization of that, but basically you can align them together. So what we do is we solve some sort of objective function, which has two terms. One is going to make sure that our solution is consistent with the observations. We don't want to output something that is completely irrelevant to our observations. And then we have some other term that's going to say, okay, the output should look like an image. So these two things need to be balanced. And this, a lot of research has gone into this over the years. So if you start from this, from 25, 30 years ago, we were looking at parallel imaging with what we call Tikhonov regularization. That is a linear solution. So if you observe more noise, you're going to get more noise at the output. So this is nice to understand, but usually leads to noise amplification problems. About 20 years ago, we got compressed sensing, which is solving this in a nonlinear manner. Then we decided to learn those linear representations. So this is still in the realm of compressed sensing. Then over the last 6, 7 years, we've been looking at nonlinear representations. So this is a natural extension of what's happening using deep learning. So going back to that slide, and this was again covered in the last talk, we could be talking about network architectures, and I'm not really going to go into too much detail, but you can spend a lot of time choosing these and the new developments, and there's a lot of work in this in our community. One example that I'm going to highlight is denoising of linear, graph reconstructed images. And here we know there's nonlinearity in the reconstruction based in terms of noise amplification that is specified by the G-factor maps. And this method takes that into account. So it takes the G-factor maps as an input as well. And then it does an SNR scale reconstruction of the data set. And then it does a denoising based on that nonlinear noise amplification that you know from the G-factor. So this was applied to 0.55 Tesla denoising, and you got some really good results in terms of the noise reduction. And this gets you to visualize high acceleration data sets. The other thing that goes into this, and again, this was covered in the last talk, is a learning task, right? How do you go from the input to the output? What kind of loss function you want to get? What kind of data you need to be able to do this? And one thing to note is we don't really have access to fully sampled data in most cases. The one work that we did was what we call self-supervised learning. And the main idea is we take our undersampled case space and we undersample it further. So we break it into two separate sets. And one set, the set that's given by theta, is what we show to the network. And then the other set we keep hidden from the network. And the network learns to predict the lambda set from the theta set. So I'm going to have a knee image there, but you can apply it to any organ as well. This goes into the data fidelity unit that I talked about earlier. So that has some physics knowledge in it, and this is what we call physics-driven networks. And then you get the output, and then you compare that to the part you kept hidden, and then you can update your network parameters based on that. And then this has applications in Algeria. We did isotropic resolution, about 1 millimeter, and you can push that up to rate 6, whereas with the compressed sensing-based method, you can only do about rate 3. And then we also applied it to real-time cine, where you can push it up to rate 8 for 2D imaging, whereas standard reconstructions are rate 4. There's no temporal regularization here. This is just spatial regularization. So each temporal frame is reconstructed independently. And the final thing that I'll talk about is image analysis. And I have 2 minutes, so we'll go through this quickly. Obviously, manual analysis is time consuming. We already talked about this. If you get a larger resolution, a larger 3D data set, it's going to be too much work for a human being to analyze. So we want this fully automated, quality controlled, and possibly get multiparametric data for decision making. So image segmentation is what we've seen a lot of times. This is a classification problems, and UNet and its variants dominate most of these works. So UNets, we've seen a lot of these. There's an encoder arm and a decoder arm, and this is a specific architecture, and there's many variants of this. And what people have shown is if you have a trained model, it will generalize. So for instance, if you have a data trained on breath health cine, it's going to generalize relatively well to free breathing real-time cine. Another thing that people showed that open source models works just as well as the commercial models. This was also a recent study. And there's a lot of work in this space for model architectures using transformers instead of convolutional neural networks or some hybrids, and then other connection types like residual and dense connections. It's also useful in speeding up time-consuming analyses, like 4D flow assessment, and we saw this in the earlier session too. How can you go from the 4D phase contrast MRI data to the velocity maps quickly? There's some work in this, and it shows that AI-based quantification is closely correlated with manual analysis. Disease classification is something that's people working on, and this is a recent study in JMRI, where they use some sort of autoencoder architecture to extract information from cardiac MR images, and were able to do some disease classification with high accuracy. And there's a lot of work in pathology detection, and reporting is probably something that most people are interested in, and this is where the connection with foundation models and text-to-image models comes into play. There are, of course, challenges. So for automatic planning, things work well if people look normal. But in the edge cases, so if you have an unusual morphology, that's where it gets tricky, and that's where it's useful to have this human interaction and the intervention. For image formation, it's similar problems. So usually these are trained on large databases. So if there's an out of distribution case, that's going to usually cause problems, especially if you're looking at very fine details. That also comes into blurring. We want to understand failure modes, the hallucinations that people talked about. The output looks reasonably well. So how can we conclude that something failed? And the other thing is, data sharing is becoming more of a problem with regulatory guidelines from institutions. Image analysis, again, the edge cases are the problem here too. Annotation is more costly. So generalizability is something that people are working on. Multi-vendor, multi-site, you want things to be able to work out of the box. And you can see that this is a general problem across all the tasks. And interpretability, which was also mentioned in the last talk, is something important that we want to understand why those decisions are made by our model.
Mahmoud.
And
If
thanks
you
to our
could-
sponsors. Okay.
Thanks so much, Mehmet. Excellent talk. Thanks so much. We'll move on to the scientific abstracts and like to introduce the next moderator taking over from us, Guo, from Tsinghua University, and Graham Wright from Sunnybrook Research Institute. Thanks again to the speakers.
Okay, thank you. And thank you for the introductions. So without further ado, we will move on with the presentations. And the first presentation in the oral section is going to be given by Vadim Malis from UC San Diego, evaluating CSF outflow using time slip MRI and bicomponent modeling.
Thank you so much. The research is supported by NIH. So CSF outflow supports brain waste clearance, and outflow metrics change with age. A non-contrast time-slip MRI visualizes CSF outflow patterns and provides quantitative metrics. Multiple studies debate, however, about the mechanism by which CSF outflow occurs. So for this study, the hypothesis was that CSF outflow comprises a fast bulk component and a slow perfusion-like component. So the purpose of the study was to propose a model that combines these two components, validates the bulk flow model in a phantom, and tests bicomponent model on the in vivo data in the healthy volunteers. So time spatial label and inversion pulse is a variant of ASL technique which alternates tag and control acquisition within a single series. So for the tag, we apply non-selective and selective pulse, while for the control only the non-selective pulse is applied. Within single series, TI delays are varied, allowing to capture time-dependent signal increase ratio. And in the previous studies, we have utilized gamma variate function to characterize the signal increase ratio associated with the CSF outflow. However, from that data, we observed that not all the features of the signal increase ratio plots are well described by the gamma variate function, which motivated us to introduce additional Gaussian term, which is given here by the second equation. And in this term, it is constrained by the indicator function just to not allow values above 0 for the time when the bolus yet didn't arrive to the region of interest, and also set it to 0 after. And there are two parameters, the delta t, which is the bolus delay, and the tau, which is the spread of the Gaussian. So the total model is given by this equation at the bottom. And to test first this bulk fluid displacement term, we utilize this custom-built phantom, which was supposed to mimic the bulk flow displacement without any perfusion. It comprises of this expandable silicon tank, which is sealed on the one side, and the other side is attached to the rigid acrylic section. The entire setup is then connected to the computer-controlled piston with variable stroke volume and flow speed that it allows us to simulate. So we performed imaging with a time slip, and you can see here on the top the tag images and the control images in the second row. The subtraction between the tag and control, these are the color maps given at the bottom. And the imaging was done using the readout, which was the single shot 2D fast spin echo, and the TI here ranges from 1 second to 4 seconds in increments of 100 milliseconds. So we fitted that data using both the gamma variate function and the proposed Gaussian with the constraints. And what we've seen in the case when we don't have any perfusion here, that the Gaussian model consistently was more superior fit for this data, which confirms that we can utilize it as the additional term for non-perfusion term. Then looking into the type slip images, this is for one of the volunteers. We had a total of 8. All of them were healthy under age of 40. So the tag images are shown at the top, and the control images shown here at the panel at the bottom. These are for the time TI ranging from 100 milliseconds all the way to 3000 milliseconds. So tag control and M0 images are those that are actually used for the calculation of the signal increase ratio. And zoomed in here for the M0, you can see this is the region that was actually utilized for the quantitative analysis, more specifically the superior sagittal sinus area, which is outlined here with a yellow curve. So looking now at the color maps on the top left, this is the tag minus the control image and the signal increase ratio color map. And I highlighted here with a white arrow, I hope you can see it. This is the actual path of the CSF outflow that we can observe. This is for the TI of 1350 milliseconds. And next to it are the fits from the signal increase ratio. So we tried here the 3 different kinds, just the gamma variate function on its own, the Gaussian, and the proposed bicomponent model. So from the metrics that we calculated from those fits, we observed that the goodness of fit was best for the bicomponent model. These are also the quantitative metrics that you can get from that fits. And on the right are the actual zoomed in regions of the tag control, the difference between tag control, the M0, and the signal increase ratio. You can see how the signal actually increases all the way to about 1200 milliseconds and then washes out. So to summarize here, the phantom experiments actually confirmed that the Gaussian model reliably captures bulk fluid motion without perfusion, outperforming the gamma variate model. And applying a bicomponent model to time slip data in healthy volunteers improved fit and accuracy. So the fast Gaussian component likely represents bulk CSF clearance, while the slower gamma variate term corresponds to perfusion-like clearance of CSF, interstitial fluid, and brain metabolic wastes. So the bicomponent model adds parameters, but applies several constraints, such as early Gaussian bolus arrival and a fixed physiologically relevant T1, which helps to maintain interpretability and minimize overfitting. To conclude, I would like to say that the bicomponent model aims to provide a more accurate characterization of CSF outflow dynamics, distinguishing between the fast and the slow flow components. So the bicomponent model metrics offer potential for future studies on age-related changes in CSF outflow, hopefully aiding us to establish some early-stage biomarkers of neurodegenerative diseases. With that, I would like to thank you.
Thanks, and thanks for staying on time. We've got time for a quick question. If I don't see one in the audience. So which of these parameters do you expect to change in this aging population? I mean, which parameters?
Yeah, there are multiple of them. Sorry, there are multiple of them, and I think some of them that might change would be the peak height, and probably also depending on the, if there is any disease, we may see increase, for example, of the actual CSF bulk motion compared to the perfusion component. So those are the parts that we expect maybe to see in the later studies.
Very nice. Thank you. Again.
So our next speaker is Dr. Patrick Winter from University of Greifswald, Germany. His talk is automatic segmentation and wall shear stress quantification of intracranial aneurysm from 40 flow using convolutional neural network. Please, Patrick.
Thank you very much for the introduction. So dual-bank 40 flow MRI is a very promising imaging modality and was already applied to studies in intracranial stenosis and arteriovenous malformations. One important parameter of 40 flow MRI is wall shear stress, and this parameter was already used as marker to characterize different aneurysm geometries. However, one problem of wall shear stress measurements is the post-processing and the segmentation of the 40 flow datasets, which can be time-consuming and prone to human error. Especially the segmentation of aneurysms can be challenging due to the presence of slow flow or flow artifacts. In a lot of cases, or most of the cases, phase contrast MR angiography images are calculated from 40 flow, sometimes in combination with the magnitude images, and these images are used for segmentation, for manual segmentation of the 40 flow data sets. Recently, we proposed a convolutional neural network for the automated segmentation of these PCMRA images, and this network is able to reduce the segmentation time to approximately 2 seconds. However, up to now, this network has not been tested yet to intracranial aneurysms, and therefore this will be the focus of this talk. So for the automated segmentation, we used a 3D UNet consisting of so-called dense blocks. This network was originally developed by Haben Bohane from Northwestern University. And Haben originally applied this network to aortic 40 flow measurements. And we applied this network then to intracranial stenosis patients. Here you can see an overview of the cohorts used for the training. This was a retrospective analysis of controls as well as aneurysm and stenosis patients. And for testing the segmentation performance, we used 3 different aneurysm cases, 2 large secular aneurysms, and 1 giant fusiform aneurysm. We wanted to test the influence of the training data size as well as the generalizability, and therefore we tested the network using 3 different training settings. In setting 1, we trained the network using the information of the aneurysm patients. In setting 2, we included 51 additional healthy controls. And in setting 3, we included even more healthy controls as well as 68 stenosis patients. And in all 3 cases, the training took approximately 10 hours. For the flow measurements, we used the dual-bank 40 flow MRI sequence developed by Susanne Schnell et al. And the measurements were acquired on 4 different Siemens scanners. And after the measurement, we manually segmented the PCMRA images using either mimics or 3D slicer, and these images were used as ground truth data. For the 3 testing cases, we used the algorithm developed by Potters and Pim van Ooy to calculate the temporally averaged volumetric wall shear stress, and this shear stress was calculated in the aneurysms. And to assess the segmentation performance, we calculated the dice scores and the Hausdorff distances, and also the spatial median wall shear stress. And for all calculation, we used MATLAB. Here you can see the results for the large secular aneurysm in the anterior cerebral artery. The top row shows streamlined presentations of the velocity values, and the bottom row, the temporally averaged wall shear stress. The left column shows the results for the manual segmentation, and the other 3 columns for the 3 automated segmentation settings. And what you can see here is that the performance was the best with the largest training data size. Surprisingly, however, the results were the worst for the mid-sized training data set. And all three segmentations showed a mild underestimation of aneurysm size. Here you can see the results for the internal carotid artery stenosis. And here we saw that with increasing training data set, we achieved better agreement. However, all three segmentations showed consistent underestimation. And we also saw that some parts were missing, which were present in the manual segmentation. And last but not least, this is the giant fusiform aneurysm. And here we observed excellent agreement with dice scores very close to 1 in all three automated segmentation settings. Here is just an overview over the dice scores and the Hausdorff distances. In summary, we can say that with increasing training data set, the circle of Wille segmentation performance increases. And in aneurysms, we saw an improvement, but just for the saccular aneurysms, not for the fusiform aneurysm. And the most noticeable improvement was achieved with the saccular ACA aneurysm. And here you can see the results for the spatial median wall shear stress. In all three automated segmentation cases, we observed a similar range of values. However, we saw a small but consistent overestimation of median wall shear stress in all three segmentation settings. And this may be explained by a consistent underestimation in wall shear stress, in aneurysm size. So to sum up, we could apply automated segmentations to intracranial aneurysms. And we saw an increase in segmentation performance with increased training data size, at least for the two saccular aneurysm cases. However, we saw a small but consistent wall shear stress overestimation. And therefore, we want to increase the training data size and also the testing cohort. But nevertheless, the automated segmentation is already a promising tool for a more streamlined analysis of aneurysm for the flow MRI data. Thank you very much.
All right. This talk is open for questions. Just a quick one. Patrick, I have one. Do you think we can make some simulation data to train this CNN network?
No, for the training, we only use the intracranial body flow cases we already had. So 68 stenosis patients, 26 aneurysm patients, and 86 healthy control cases.
Do you think we can generate some simulation data?
This should possibly, yes.
Okay, all right. Questions? No? Okay, Ray, please.
Yell. Just yell.
Sorry, again?
Bank.
Yes, we used all training data sets were dual bank polyflow measurements. Well, in aneurysms, you see the problem is with intracranial forward flow. You always see components with high velocity and also with low velocity. And for a single bank, you would set the bank to, for example, 120 centimeters per second. And then you would get very low SNR in the aneurysm, because in the aneurysm, you will observe very low velocity values. And therefore, SNR is not that good in aneurysms. And therefore, the PCMRA images created from these data sets will also show low SNR. So in fact, so I think 2 days ago was a comparison between single bank and dual bank for the flow MRI in intracranial, and they could also see that a significant difference in velocity noise between single bank and dual bank. So yeah, dual bank gives us a SNR improvement.
All right, thank you, Patrick. Thank you.
Okay, our next speaker is Eniko Pomozi from Houston Methodist, and she'll be presenting on quantitative MRI relaxation time analysis of ex vivo thrombus samples, implications for mechanical thrombectomy and clot characterization. Eniko?
Thank you for the introduction. Good afternoon, everyone. I would like to show our work on MRI relaxation times on ex vivo human thrombus samples. So venous thromboembolism is not just an acute problem. The first-line treatment is anticoagulation, but even with proper anticoagulation, these patients are at risk of further complications. Mechanical thrombectomy has emerged as an alternative therapy, and for example, the CLOUT registry showed us results that showed the hospital stay length shortening and best outcomes after mechanical thrombectomy. But here's the problem. We have currently no reliable imaging biomarker that shows us the clot age and composition. And this is a major problem because procedure success heavily depends on these parameters. So our study aimed to identify that MRA relaxation times can even serve as biomarkers for thrombus age. And of course, we wanted to validate this data with histology findings and assess how formalin fixation affects these relaxation times for further standardizing ex vivo protocols. So far, we collected 20 thrombus samples from 12 patients who suffered deep venous thrombus pulmonary embolism or arteriovenous fistula thrombosis. We estimated the clot age in days from the first symptoms until the day of the surgery. We got these clots that were removed via open or endovascular thrombectomy. We scanned these clots in an ultra-high resolution 9.4 Tesla MRA. 15 samples were scanned at their fresh state, and then after formalin fixation, it enabled repeating measurements. For post-processing, we used the program Osiris. T1 maps were created by saturation recovery technique, and T2 and T2 star maps were created by mono-exponential fits. We actually created a mask that covered the entire clot volume, and if it was not applicable, then we did it manually. Here are some of our results. First, the effect of formalin fixation. We found that T1 and T2 relaxation time decreased significantly post-fixation, with the most changes occurring in the first 6 hours. T2 values followed a stable decreasing trend, while T1 values were highly variable, indicating that formalin fixation affects water retention unpredictably. T2 star value showed a moderate reduction, and this value had the most outliers, which indicated that formalin might disrupt the usual iron breakdown. Second, the clot age effect. We found significant negative correlation with the clot age and T2 relaxation times. T2 star also trended downward without statistical significance, but T1 value did not show significant correlation with clot age. Third, about the effect of clot type. So we observed no significant difference whether the clot was a DVT, PE, or AVF thrombus. We also sent the samples for histology analysis, and different staining methods and immunohistochemical processes were applied to actually uncover the underlying composition and dominant tissue type like red blood cell, fibrin, platelet, or collagen. And we have initial data from 12 of the 20 specimens that we collected, and we actually paired them with our MRA findings. And we found that red blood cell content demonstrated strong negative correlation with T1 value, while collagen content showed negative correlation with both T2 and T2 star relaxation time values, T2 star being statistically significant. In conclusion, we can say that ultra-high resolution 9.4 Tesla MRA shows unprecedented clot visualization, and we can actually detect clot age with MRA relaxation times because it reveals the underlying composition. Looking forward, our study supports the development of clinical MR biomarkers at even lower field strength scanners. And ultimately, we hope that these findings will match the right patients with the right treatment and minimize procedure errors and improve outcomes in thrombosis care. Thank you so much for your attention.
Very nice talk. Talk's open for questions. Again, quick one. Did you look at the different iron states from deoxyhemoglobin, methemoglobin, hemosiderin, and whether or not that made any difference?
Not yet. That's next step of our study. But of course, for example, T2 star values are strongly dependent of these iron components and how they can change relaxation. So that's a correct question. Thank you so much.
Great, thank you. And the question up there from.
Not really, sorry.
Just give us the tight question.
Thank you so much for the question. Yes, this will be also a next step for our study because now we're just doing this ex vivo imaging, and the next steps will be to actually implement our results into more clinical settings. So yes, thank you.
Okay, thanks, speaker again.
Thank you so much.
Okay. So the next speaker is Xiangcong Liu from Tsinghua University at China. His talk is assessment of wide coverage intracranial and extracranial vessel wall MI at 5T. Please.
Yeah, thank you very much for your kind introduction. And good afternoon, everybody. I'm Liu Xiangcong from Tsinghua University, and my supervisor is Professor Li Rui. And today I want to share my manual work about the performance of 5T intracranial and extracranial vessel wall imaging. And first is the background of my study, and cerebrovascular disease are characterized by high incidence, high mortality, and diagnostic challenges, posing a serious threat to the human health. And this makes accurate diagnosis of cerebrovascular disease especially critical. And magnetic resonance vessel imaging can non-invasively depict the morphological features of vessel walls. So the current guidelines for the cerebrovascular disease prevention and treatment strongly recommend MRA vessel wall imaging as a first-line examination for the patients. However, the most prior vessel wall imaging are conducted on 3T. Well, the recently introduced 5T MRI system, owing to its high mean field strength, stronger gradients, and whole body imaging coil, now enables vessel wall imaging of even higher quality. So as a completely new platform, the 5T vessel wall imaging still requires high further investigation into the image quality assessment and sequence optimization and clinical applications. So therefore, we designed a series of experiments to investigate the performance of 5T vessel wall imaging. So in this study, we use 3 coil combinations as shown in the above figure. They are head and neck coil along with a separate carotid artery coil, head and neck coil, and transmit receive head coil. We can call them as HNC coil, HN coil, or TR coil for convenience. And the T1 weighted 3D TSC sequence can achieve isotropic resolution of 0.6 millimeters, as shown in the table below. And the picture on the right shows the experimental procedure. We recruited a total of 10 healthy volunteers, and for each volunteer, we perform independent scans using each of the 3 coil combinations mentioned above, with a 3-minute rest period between each scan. And all scans were performed with identical scan plane covering the common carotid artery, internal carotid artery, and middle cerebral artery. And then the curve of the multiplanar reconstruction was performed to obtain cross-sectional images of the blood vessels for subsequent image quality and consistency analysis. So the reconstructed CPR images from CC to MCA are shown in the middle picture. So we can find that good vessel delineation and blood suppression over the entire arteries were found on the images when using HNC coils. And when using HN coil, good vessel delineation and blood suppression were found on images above SAC1 level, while images of CCA and carotid bifurcation showed less clear vessel boundaries. However, when using TR coil, and the images of carotid arteries showed almost no discernible vessels. And then we select 6 locations of blood vessels and score their vascular delineation ability. And all the images were independently reviewed by 2 experienced observers. And the delineation ability decreased from good to poor as the scores goes from 4 to 1. And the inter-reader score results indicate that the overall image quality of HNC coils is superior to that of HN coil and TR coil, particularly in the images of extracranial arteries. After that, we calculated the signal-to-noise ratio of the vessel wall and the vessel lumen, as well as the CNR. And compared to the other type of coils, and using HN coils has better delineation performance in the carotid arteries. And we also imaged for 4 patients with cerebral vascular disease. And the images on the right show that the 5T can clearly show the vascular lesion, such as vessel thickening and atherosclerotic plaques. And in consistency analysis, we measure the wall area and the lumen area of the same site from the 2 scans using HNC coils. And then we obtain the blind outline plots for the 6 locations, where the y-axis represents the difference in area, and the x-axis represents the average area. And the blind outline plot demonstrates that no significant bias was observed for the 6 locations. And finally, we conducted a comparison among different field strengths. And here are the large coverage vessel wall images of the same healthy volunteers acquired at 3T, 5T, and 7T. And we can clearly see that the 5T images not only has a clear vessel boundary, but also has a higher signal-to-noise ratio of the entire pictures, images. So in conclusion, the 5T black blood vessel imaging in this study can simultaneously achieve high resolution and large coverage, which is difficult to achieve using 3T or 7T alone. However, this work still has certain limitations. Firstly, the B0 inhomogeneity of 5T can lead to the loss of image signals in some volunteers, which need further improvements. And secondly, the sample size in this study is relatively small, which may affect the generalizability of the results. So the future advancements should focus on optimizing the sequence design further and conducting large-scale population studies. So that's all my main work. Thank you for your attention.
So this talk is open for questions. Any question? A quick one. Xianzong, maybe I can ask you something. So for this 5T and the 7T acquisitions, did you use any like a B1 shaming to correct for the B1 homogeneity?
We didn't use B1 shaming.
Even for 7T, you didn't use any B1 shaming?
Oh,
PTX or PTX?
Oh, sorry, we use the PTX.
Okay. So you also see some like a fat separation issues?
Yeah, we use the fat saturation of 5T and the spur in the 3T.
Okay. Other question? Oh yeah, please.
Yeah, this is the limitation of my study. Yeah, we didn't sets the same resolution for the 3T and 5T and 7T. Yeah, we in the future we will increase the resolution of the 5T to 0.5 millimeters and to the same as the 7T. Yeah, this we'll do in the future. Thank you for your questions. Thank you.
Okay, thank you, Xianzong. Thank you.
Thank you.
Okay, thank you. Our next speaker is Mona Karaji from UWashington to speak on quantitative intracranial vessel wall imaging features in differentiating intracranial vasculopathies.
This is the last time I'm going to trick you guys today. So I'm presenting from Mona Karaji, my fellow, who was not able to make it. So based on the survey paper that I mentioned a little earlier, we found that intracranial vasculopathy differentiation is the most common application for intracranial vessel wall MR clinically. The survey indicated that 95% of groups perform it for this purpose. Now, we've published a number of papers looking at qualitative features and criteria that can differentiate intracranial vasculopathies, as have other groups. The challenge there is that these qualitative criteria carry different definitions based on different groups, and there really is a lack of consistency in terms of interpretation and approach to the imaging. So in this study, and really, you know, what I've always wanted to do is look at quantitative features to differentiate these vasculopathies, and so that's what we did here with one of the coffee-based software programs that Trun was talking about earlier, MoCA. And so we looked at clinically defined cases of intracranial vasculopathy, specifically atherosclerosis vasculitis and RCVS, and we processed the imaging through this MoCA pipeline. Which it's a semi-automated process. There's a deep learning component that does the centerline tracing, after which we correct it, and then it does the wall segmentation as well. And similarly, it has that CE map that was discussed previously. 3 radiologists reviewed the segmentation and then corrected it as was needed. And here's just another presentation of the software interface. That CE map is another component that was discussed previously where it can quantitate the degree of enhancement within the lesions. So for each lesion, we extracted a number of features, including lesion length, wall thickness, percent wall volume, eccentricity, the degree of enhancement with 2 different quantitative metrics, and the percent enhancing volume. So what we talk about here is we processed 14 atherosclerotic cases, 6 vasculitis, and 10 RCVS. Now we've processed about double those cases in terms of the total data that we have now, and hopefully we'll be finishing that up soon. But in terms of that quantitative analysis, vasculitis showed the longest lesion length, and it also showed the highest percent wall volume in terms of the amount of the lesion that enhances, while atherosclerosis showed the maximum wall thickness of a lesion, as well as the highest eccentricity index, followed by vasculitis and then RCVS. So in terms of enhancement features, the enhancement features were significantly higher for vasculitis relative to the other disease processes. In addition, atherosclerosis was significantly higher than RCVS. And so just to show you how these imaging ends up looking like on the CE map segmentation component, you can see here's the vasculitis lesion. You can see that's homogeneously intensely enhancing, the highest degree on this scale. Atherosclerosis is much more heterogeneous and somewhat intermediate with variable areas of enhancement. And then RCVS is really low on that scale. So in conclusion, quantitative vessel wall imaging, vasculitis generally shows longer lesions with lower degrees of eccentricity and more intense and diffuse contrast enhancement compared to the other disease entities. Atherosclerosis has intermediate values, both in terms of enhancement, while its wall thickness is higher than RCVS, but less diffuse than vasculitis. And then RCVS shows the lowest values, including wall thickness and enhancement. And that's mainly because RCVS represents a vasospastic process. It's not an infiltrative or inflammatory process. Quantitative vessel wall imaging features can improve diagnostic accuracy in differentiating intracranial vasculopathies. The next step that we're working on currently is to finish up our processing and hopefully develop quantitative thresholded values and predictive models for differentiating intracranial vasculopathies. Hopefully that'll make interpretation of these studies easier and more straightforward and reduce that learning curve for new radiologists that are using vessel wall imaging for vasculopathy differentiation. Thank you so much. And here's that lab picture. This one is Muna right here. Right there. You guys can't see my pointer, can you? I do.
And thank you again for the talk. It's open for questions. Again, it may be associated with future work. Obviously, this is a very rich data set with multiple parameters. So do you see kind of more of a multi-parametric predictive model where you're going to combine different measures? And how do you take out, I mean, I assume a bunch of the measures are quite correlated.
Yeah, so that's hopefully the goal, is that we will create a multi-parametric model for differentiation between diseases. And what I'll say is the metrics that we found here in terms of quantitative features really do mirror what we've seen on the qualitative descriptions. The main challenge is everyone's definition of things is different. You know, in the literature, you know, eccentric has 5 different meanings, whether it's greater than 50%, whether it's concentric, whether it's greater than 50%, whether it's 100%, whether it's, you know, the thickest is not thicker than twice the thinnest. So there's a lot of definitions out there, and the goal of this is just to standardize and threshold and create a single kind of model that we can use to differentiate diseases.
Great, thank you. Any other quick questions? If not, thank the speaker again. And we'll move on to our power pitches.
Right. So for each power pitch, it takes like 3 minutes, so therefore it's quicker. So the first one is deep learning-based reconstruction of highly accelerated 4D flow MRI using larger than 1,000 datasets. The speaker is Dr. Haben Benhe from Northwestern University, USA. Please.
Sorry, I'll be continuing the substitutions here. Figure out how to go back. So I'll be presenting this on behalf of Haben, and he gave me quite a mountain of material to go through, so let's jump in. The basic premise or consideration that we have here is that 4D flow MRI obviously gives us very valuable hemodynamic information, but it takes a long time. And so there have been efforts to try to speed it up using techniques like compressed sensing. But there's also been work showing that using these type of reconstructions and acceleration strategies can result in underestimation of certain hemodynamic parameters. So what this sought to investigate was whether a different type of reconstruction using a fluid physics informed CNN could perhaps more faithfully allow for reconstruction and quantification of hemodynamic parameters.
I will give them.
So here let's just focus on the left side. It's describing the different training and testing sets. At the top, there were about 1,000 retrospectively undersampled 4D flow data. So they were originally fully sampled and then retrospectively downsampled at 5.7, 7.7, and 10.2 acceleration factors. There was a separate set of 100 data sets that were used for testing, undersampled in the same way. And then a small group of prospectively acquired data, which were accelerated by the same degree, but the scans were prospectively acquired. The basic setup for the model uses 2 different CNNs. On the top, there's one that will reconstruct the magnitude images. And then at the bottom, there's another one that has 3 output layers to generate the velocities altogether using this fluid physics space loss function. Here, we'll first look at the magnitude images in the retrospectively undersampled testing data. You can see at the top, the visual quality of the magnitude images is fairly well preserved. There's fairly high similarity using the SSIM metric, even at the highest acceleration factor. When we go to look at the prospectively acquired data, we have both a CNN reconstruction and a compressed sensing reconstruction, so they're interleaved there. You can see as you go to the highest acceleration factor from left to right, still the visual qualities are pretty well preserved. At the highest acceleration of 10.2, the CS is starting to fall apart a little bit. But what we really care about is the velocities. So if you quantify peak velocity in the retrospectively undersampled testing data, you see that the peak velocities are pretty well preserved. It's a little small, but they're fairly similar, even at the highest acceleration factor. And you can actually maybe see that a little more clearly on this table, where only the ascending aorta has had some differences in the peak velocity at the highest acceleration. We'll just jump through to see here. Now we have basically the same kind of evaluation, but with the CNN and the CS. Columns are interleaved again, and the CNN is, again, not showing that many differences, whereas the CS is clearly falling apart at the higher acceleration factors. Thanks.
Okay, thank you. And again, for the power pitches, there won't be questions, so we encourage you to seek out the speakers at dinner. Our next talk will be given by Vincent Lechner from Karolinska, speaking on imaging relative pressure fields through turbulent flow domains, combining ICOS A6, 4D flow, MRI, and physics-based full field pressure estimators.
Yeah, thanks for the intro and hey. Okay, so of course you've heard a lot about 4D flow MRI in this conference, and of course it allows us to essentially measure full field velocities throughout different cardiovascular sections. But what we can also do is actually use fundamental fluid mechanical principles to derive on the basis of these flow fields for one end-to-end pressure estimates, but also actually really full field regional relative pressure maps. And this is pretty nice because for one, it allows us to non-invasively assess, clinically established biomarkers related to pressure. So for example, this would be relevant for aortic coarctation, but also you can try to develop new biomarkers based on imaged velocities and reconstructed pressure, for example, for aortic dissection. Okay, but not all flows are really equivalent in complexity, and you've also heard about turbulent flow. And basically what I mean is, again, it's kind of a reiteration. So flow that is very, very hard to predict on the observable spatiotemporal scales. And this is really an issue for these estimators because these estimators were not really built with these types of flows in mind. But with new sequence designs over the last couple of years, like ICOSA 6, we can actually measure or try to measure these contributions that arise in these turbulent flows. And so the aim here has been to establish and evaluate regional relative pressure mapping techniques in turbulent flow regimes. Briefly glancing over the methodology, so we're acquiring velocity and covariance is kind of linked to the turbulent activity of the flow. We use the Reynolds average Navier-Stokes equations and then derive or extend two previously existing full field pressure mapping techniques into the turbulent regime. And I want to emphasize this term here because this is really what we're acquiring with these types of sequences. And in the end, this allows us to generate, or to map pressure over space and time. Okay, of course, we would like to assess method performance. So we have a couple of different test beds here available. We have an in silico stenotic case over different flows and also stenotic intensity from collaborators at the University of Linköping. We have an in vitro, it's kind of a similar data set, but actually an in vitro flow phantom with measured end-to-end pressures available from Ho Jin Ha. And then we have a pulsatile in silico test case from Mia Bonini at Michigan. And this is really here to have like a more physiologically correct flow field. So this is a very severe aortic stenosis. Some preliminary results. We have, the non-turbulent estimators. If you compare measured pressure against observed, reference pressure per voxel, you see that correlations increase pretty drastically between the turbulent and non-turbulent methods. You see something similar for the in vitro example, for the end-to-end pressures. And finally, if you actually look at the error distributions, you can see that spikes in the error fields. I'm showing here the absolute error between reference pressure field and estimated pressure fields. They're kind of spatially correlated to the turbulent activity of the flow. And these also perform much better with the turbulent estimators. Okay, so a bit over time. In summary, this allows us to effectively do this pressure mapping in turbulent flows. And the results essentially suggest that this is also working. And finally, how impactful it is, is subject to further investigation. And we are doing that. And yeah, thank you.
All right, thank you. So the next talk is deep learning image-to-image translation from CEMI to CTA, where conditioned diffusion. The speaker is Dr. Ethan Johnson from Northwestern University. Please.
Thank you. Hello again. So maybe we can take a little more time with this one. So the basic premise here is that patients who are being monitored for aortic disease receive potentially a mix of modalities for imaging the aorta, so CT and MR generally, and that limits the ability to compare across time in these patients. So the idea here was a preliminary investigation to try to generate synthetic CT images using the MR images from a patient. There was some pre-processing in which basically the CT volume was treated as the fixed volume and the MR angiographies were registered to it. These were acquired in the same patients within 1 year. And so it was a somewhat small group of patients. It was 40 patients who had these. With all the data sets registered, then 38 of them were used for training the network on a slice-by-slice basis. So it's a total of about 2,000 slices. And then 2 patients' data sets were used for testing, about 140 slices. The model is a modified version of a MONAI network. So this is essentially a diffusion network that will try to kind of successively denoise. This was modified to take the MR angiography images as a conditional input. And then the noisy process will, over time, as we're seeing here, turn into synthetic CT angiography. So that's what we just said. Here you can see an example in one of the 2 test data sets of doing the inference. On the left is the input MR angiography. In the middle is the CTA that was generated. You can see there's probably still some unresolved registration issues because the size or orientation is not quite the same. But then if you compare it to the actual ground truth CT angiography, visually the texture is fairly similar. There's a similar pattern of intensity changes as you go from, in particular, some of the anatomy that you're interested in, the aorta and the spine. And so just as a kind of quick evaluation of the similarity, the signal intensities in the images were compared. The aorta signal intensity was not the same as the ground truth, but it did manage to preserve kind of the difference between the aorta and the spine. So obviously this has been a kind of preliminary study. There are several limitations. It was a small cohort, which would need to be increased to really understand if this works well. There were definitely some issues with the registration. This needs to be improved. And there was not a very rich examination of the quality of the output. But this may help allow for doing serial comparison in these patients who are receiving clinical monitoring. Thank you.
Thank you. Our next talk will be given by my co-moderator, Hua Guo, from Tsinghua, and it will be on susceptibility enhanced vascular imaging at 5T, a feasibility approach to decode cerebral small vein networks and cerebral microbleeds.
All right, thank you. So this study is part of our Parkinson's disease study on 5T. So we all know conventional MRI at 3T may have like a low sensitivity for sub-millimeter veins and small microbleeds. Therefore, ultra-high field SWI on the QSM can improve the detection of those abnormalities. So therefore, the purpose of this study is to evaluate SWI QSM performance at 5T and compare with 3T. We want to detect sub-millimeter microbleeds and small veins. So the acquisition parameters is shown in this table. Basically, we acquired 3 echoes. Resolution is 0.5 by 0.5 by 2. And we use a sense of 2.2, and the acquisition time is 8 minutes. So here's a subject from 5T. So On the left is the third echo of the magnitude image, and this is the SWI and the MIP QSM. This is another slice. And this is the PD patient result. Again, this is the magnitude image, SWI, MIP, QSM. We can see some small lesions. It can be less than 1 millimeter long. Also, QSM confirm the hemorrhage in those regions. Okay. When we compare the 3T results, this 5T does show high ISNR and better contrast. So this is 3T SWI, this is MIP, this is 5T results. So to summarize, 5T SWI QSM can enhance detection of sub-millimeter microbleeds and small veins. It offers high resolution visualization of small venous structures. For the limitations, we have acquired a very small sample size. Also, it lacks comprehensive comparison with 3T. In future, we will improve this and by adding statistical analysis. With that, thank you very much for your attention.
The next speaker is Jiantong Ji, also from Tsinghua, and she will speak on development of a clinical tool for LSA segmentation, leveraging 3D data for 7T LSA segmentation with an NNUNet and SWIN UNETR.
So thank you for the introduction. Good afternoon, everyone. My name is Diantong Xie, and today I will discuss our work on automatic segmentation of the lenticulostrate artery, or LSA, using deep learning to bridge 3T and 7T MRA data. And I have nothing to declare here. The LSA is critical in neurological conditions like stroke and Alzheimer's disease. While 7T MRA clearly visualizes the LSA, it's not widely accessible, and the manual segmentation is challenging. Our goal was to train models on 3T MRA data to automatically segment the data in 7T data, creating a clinical useful tool. We used the CAS 2023 challenge dataset, which includes 3T TOF MRA data from 100 patients with intracranial artery stenosis and corresponding segmentation masks. Two deep learning models, NNUNet and SWIN UNET-R, were trained with data augmentation techniques like spatial cropping, flipping, intensity normalization, and for SWIN UNET-R, resampling to 0.3 by 0.3 by 0.6 millimeter resolution. We evaluated the performance using recall as a primary metric and dice loss as a loss function. For testing, we used the 7T TOF MRA data from 12 patients of Beijing Tiantan Hospital, and our results were shown in the table indicate that both models achieved reasonable segmentation on 7T data. Notably, SWIN UNET-R outperformed NNUNet, likely due to its advanced resampling strategy. And the visual results are presented here, and in figure 2 is 2D. And the 3D results are presented here in figure 3. In conclusion, our model trained on 3T data show promising generalization to 7T data. The results are preliminary due to the small test sample. SWIN UNET-R's superior performance highlights the importance of tailored data augmentation. Moving forward, we plan to expand the test dataset and explore new structures to enhance the robustness. I want to thank all my colleagues in CBIR, and I also want to thank SRMA. Thank you so much for your attention.
So the next talk is automated cardiovascular MI protocoling for common cardiac indications using natural language processing. The speaker is Dr. James Carr from Northwestern University. Please.
Okay, good afternoon, everybody. Thanks for staying till the near bitter end. I too am presenting this work on behalf of one of my students, Malika Shavgat. This is her work, and also the work of Adrian Klein, also listed here. Here are my disclosures. So we've heard in this session that CMR is a complex exam with many techniques in a single protocol. And protocoling the study is actually a significant cause of time consumption for physicians during the regular workflow. So we created this natural language processing based system to try to automate protocol selection. So it's not done manually by physicians. So we performed this using a retrospective chart review of about 1 to 2 weeks of cardiovascular MR work at 3 of the locations on the downtown Northwestern Medicine campus, resulting in a total of 305 protocols, of which 5 were excluded. So the final number was 305. This is the tool itself. It was coined RADSeq by Dr. Klein. You see the clinical information is listed on the left, and then this maps to the appropriate protocol, hopefully one protocol. It also lists the ICD-10 codes and collects any mention of hardware in the patient, which may be relevant for protocol selection. So this is the NLP tool that was used in methodology. I'm not going to speak to this very succinctly or confidently. I will highlight 2 areas. One is the synonym map, because as you can imagine, when protocols or clinical information has been entered, sometimes it's very unclear what's actually been asked. So the synonym map enabled identification of key disease terms to map them to the appropriate protocol, as well as the indication mapping was rules-based and used fuzzy logic to, again, to map clinical phrases to the appropriate type of protocol. Here are the results. We achieved an exact protocol match, so a one-to-one match about 75% of the time. When you added in a one-to-many match where more than one protocol was selected, but one of those protocols was correct, this resulted in an increase in accuracy to 87%. So this is really a significant time saving for automated protocol matching. So the initial work, this is just proof of concept, showed promising results for automated protocol matching. We plan to enhance this model over time beyond synonym and regex matching using LLM fine-tuning. Again, continue to test it. There are plans to expand this to other modalities, particularly CT and other clinical areas such as body or neuro. And I'd like to acknowledge the MRI staff, particularly Marcy Messina. Thank you very much for your attention.
Okay, thank you. And just to check, the last speaker listed in the program, U10, I don't believe is here. Is that correct? Okay. With that, then, we will close the session. Thank you all for your attention, and thanks to the speakers for the great talks, and see you all at the dinner tonight.
So those there have the contact with